Thank you, Chairperson. Good afternoon, ladies and gentlemen. At the outset, I'd like to thank Dr. Krishna and Dr. Vijay Kumar for giving me this opportunity to discuss this session. This session on the symposium of challenging patients, some challenges which we face in our day-to-day practice dealing with patients with diabetes. So, when I was discussing with Dr. Krishna, he was saying that we will have a session something like this. We'll have so the agenda of my presentation would be a couple of case presentations on patients diabetes with obesity, how to evaluate them bedside, what are the challenges with regard to the management of such patients, and a little discussion on the monitoring and treatment issues, and invite some opinion from the experts, and a couple of points on future directions with regard to the research avenues with regard to therapeutic applicabilities. So my first case would be Mr. A, who is 52 years old, a non-diabetic patient for the past 9 years. He has associated hypertension, dyslipidemia, and a stable coronary disease. He has a high-flying job, which is quite stressful, and has a sedentary lifestyle, and he is a smoker, occasionally takes alcohol, and he has an irregular and highly irrational dietary pattern, which is expected from such executives. And his BMI is 31 kilograms per square meter, waist circumference is 98, and he has mild acanthosis. So all of them note that we have a patient with gradual obesity with acanthosis. He is currently on a combination of sulfonylureas, metformin, and DPP-4 inhibitors. His fasting is 176 and PP is 284 milligrams and A1C is 9.2. Quite obviously under poor control. So the point of discussion here would be the patient's current problems. This patient, obviously he has an uncontrolled hyperglycemia. So what would be the ideal A1C target for this patient? So let me go about discussing, and in between, if any of the audience have some kind of opinion or reservations, they always welcome to discuss. So this patient, we know to fix the A1C target, previously we had been having a target-oriented approach, but now the latest ADA and ESD guidelines of 2015, they recommend an individualistic approach with regard to fixing an A1C goal. So this patient, we know we have a patient who is already 52 years old, of a long duration of diabetes of 9 years, with associated comorbid conditions, who has a poor lifestyle and who is obese, and who is not under very good control, and he has not much of a motivation with regard to lifestyle issues. So when fixing a A1C target for this patient, I think it would be reasonable to fix a A1C target of about 7 or 7.5, 7 to 7.5%, which if we achieve within a period of 3 months, would be ideal for this patient. So that is with regard to fixing an A1C target for this patient. Of course, the next issue is the presence of associated comorbidities. He has hypertension, he has dyslipidemia, and all these comorbidities have to be taken care of. And then the lifestyle issues. He has poor dietary compliance and lack of physical activity. So all those things have to be taken care of. And of course, the current anti-diabetic therapy that the patient is on is again a problem. He is currently on a combination of sulfonylureas, metformin, and DPP-4 combination, with which the patient is not under control. So, patient already being an overweight, obese individual, my personal opinion would be to take off the sulfonylurea, continue with metformin because that is the drug which has been advised by almost all recommendations as the first line drug. So, we'd like to continue metformin, and then DPP-4 inhibitor can be continued, or a better alternative would be a GLP-1 receptor agonist, which would help in promoting weight loss as well as gaining good glycemic control. So these are some of the possibilities which we can think of while treating the patient further to achieve a good glycemic control of about A1C of 7.5%. So this is with regard to the management of the patient at present. And then how do we manage this grade 1 obesity? Of course, the basic thing is again lifestyle modification. He has to follow a proper lifestyle, proper dietary compliance, along with good physical activity, which we have to promote by way of diabetes education. And then, what is the role of anti-obesity drugs? Can anti-obesity drugs be used in this patient? Previously, we used to have some anti-obesity drugs like Rimonabant or Orlistat, fat blocker, Orlistat, and all those things, but nowadays they are not widely being prescribed for patients with treatment for obesity. So the current role of anti-obesity drugs with regard to the treatment of obesity is very limited. And then the next question is with regard to inflammation. See, we all know theoretically inflammation plays a major role as far as patients with diabetes and obesity is concerned. So there are several inflammatory markers which have been shown or proven to play a major role in the pathophysiology of diabetes complications in patients with obesity, like your interleukins and other things. So do anti-inflammatory drugs play a role in managing these patients, in the at least in the prevention of complications? So these are some of the discussing points that I have. So to move further, these are some of the points that I would like to present as a message. These are some of the future directions with regard to research and especially with reference to therapeutic applicability. There are certain newer anti-obesity drugs which are available, which are going to be maybe available in the near future. The neuropeptide Y receptor antagonists, the MC4R melanocortin 4R agonists, neuropeptide agonists, intranasal peptide YY, they're all in the pipeline, may be available in the future for the treatment of obesity. And then we have newer anti-diabetic drugs in the pipeline which may be useful in treating patients with obesity and diabetes. Maybe the long-acting GLP-1 receptor agonists. Then your fatty acid oxidase inhibitors like methyl palmoxylate or etamoxib. Then the LPL stimulators like protein lipase stimulators, glucokinase activators like piraglutide. These are all some of the things in research which may be available in the future. And then one particular place where I am interested is the role of brown fat. Brown fat, we all know, is brown fat is a type of fat like your white adipose tissue, brown adipose tissue, which is present in all human subjects, even in the adult life, and which helps in dissipating energy and losing weight. And so brown fat, which is not activated in adults. Now, if you want to activate brown fat, there are several activators of brown fat like exposure to cold and all those things. And there are brown fat targeted therapies, especially in BAT negative individuals, the obese individuals with BAT negative. There are certain brown fat targeted therapies.
Since we have a little less time and you also have one or two more cases, should we move on to the discussion of this particular case?
I am finishing with this slide, ma'am, and we will move on to the discussion. So these BAT enhancing strategies, they show like FGF21 or IRIS, they show promise in the treatment of obesity, which may become treatment targets in the future. This is with regard to my discussion. And of course, inflammatory markers in obesity, they can also play a role in evaluation in the future. And anti-inflammatory drugs like chloroquine, interleukin-1 receptors, antagonists, NSAIDs, they may play a role in the future. So as of now, therapeutic strategies with the lifestyle modification, which integrate glycemic control and weight loss, will assume greater importance in the treatment of patients with diabetes and obesity. So let me stop with that with regard to the first case and invite experts' opinion and interaction with the audience with regard to the management of this particular patient, diabetes and obesity.
This is quite a run-of-the-mill routine case that many of us see. Is a 52-year-old sedentary person who is obese and has a BMI of 31. There are two things that came to my mind. One is that I don't think 52 is really old, because he said this person is already 52. I don't know what you meant by that. 52 is not really old. So A1C for this person need not, it needs to be individualized, but we can be stringent with HbA1c because he also has comorbidities in the form of dyslipidemia and hypertension. So to my mind, yes, you can hope for an A1C that is less than 7, maybe closer to 6.5 because he's 52, not so old, and we can try to achieve that. So to that end, my target in this person would be that despite so many OADs, the problem is that his A1C is still at 9.2. So you definitely need some methods by which you can reduce his weight first. With that, a lot of things can get normalized. So GLP-1 analog, you can cut the DPP-4 and you can try and try a GLP-1 analog if the patient's pocket allows and if he is agreeable. That is the first thing that I would say. Second thing is you can up the dose of metformin, and as you rightly said, the sulfonylurea, you should try to reduce it as much as possible because you are already giving a DPP-4. And a good counseling. Now, I know that we hardly have any drugs for obesity that are approved in this country as of now. You only have Orlistat, which in my opinion is not a very great drug to try and reduce weight. It can just at best be a supplement, but there are other ways to reduce weight, and that should be really implemented aggressively other than pharmacotherapy, because exercise didn't really feature much, and that is very, very important. So that is about it. Secondly, what I saw was that your postprandial is really, really high. It's 284. So I think alpha glucosidase inhibitors, I know I debated against it yesterday, but I do feel that alpha glucosidase inhibitors, especially in the light of, if you heard the plenary and heard Dr. Anup Mishra, yes, it has a role. And that is also again weight neutral. So these are some of the changes you can make in this patient. Cut the sulfonylurea, cut the DPP-4, add a GLP-1, and perhaps also add an AGI or one of them. So anti-inflammatory I can't talk about right now. I know hydroxychloroquine is making a bit of a news now, but we don't know endpoints and we don't know whether it's going to be, really useful. But yes, that's a thought for the future.
To clarify on your first comment, ma'am, with regard to the age, this patient is what I commented on already, 52 years old.
Yes.
He's chronologically 52 years old, but then to consider the vascular age, we know diabetics are 10 years older than their chronological age.
Yes,
So we should take the vascular age more into opinion,
all the more reason
more into consideration.
that you have to be a little aggressive on this patient, because you can have a multi-pronged approach with this.
Yeah, I think
No, I'm not saying very stringent, but then if he's doing well otherwise, he has these risk factors, he doesn't already have any disease. Okay, so if you have evaluated his cardiac status and you find that he's okay, and we don't know how long ago his dyslipidemia and his hypertension have started, we should give him the benefit of the doubt, is what I feel, because he's not yet that elderly, as even if he has a mild atherosclerosis already, he's not reached the time where he already has heart failure or he has a bad ejection fraction or something like that. So I think he should be given a fair trial of a good stringent control.
Yeah, I think the issue is that you need to differentiate between those people who have got the comorbidity is not very severe in this patient. If you look at all patients with diabetes, you will have almost 70% of them will have comorbidities. If you are going to up the HbA1c target for all of them, then you'll end up not having a sort of good control in most of our patients. So I think this patient has a very low risk of hypoglycemia, and he is a person who can sort of be more strictly controlled in terms of his HbA1c target. Yeah, I think
if you have
any other issues? Yeah. Well, I think with the weight already being a problem, and yeah, as a
stable CAP, probably injection fraction is normal, maybe 21 function.
That would probably not be the first choice of medication that you would look at. You would, but to add on to the existing therapies, I would not think of it as the first instance, because of the fact that his weight is already an issue, and you expect that there may be further weight gain in that. And so I think that won't be my first choice in this situation.
Apart from that, along with the GLP-1 agonist, if you are particularly targeting about weight loss in this patient, if his pocket allows, why not add SGLT2 inhibitors? We don't have any data in that, in particular Indian data. Along with metformin plus SGLT2 inhibitors plus GLP-1, that could be furthermore to achieve good HbA1c control without inducing much more hypoglycemia.
That's actually a very good suggestion, because you do lose some weight with SGLT2 inhibitors. Yes, that's an option. Like I said, if GLP-1 analog being injectable is not acceptable to the patient, or cost-wise, I think it would be, the SGLT2 inhibitors are also expected to be expensive. They are expensive, but yes, that's another. So we should go, for this patient, I agree that we should go more and more for therapies that would help him lose weight. Because to my mind, 50 or 60% of his problems will be solved with weight loss. So we should go there first. That's what I think. As I said, there are lifestyle modification. He is a sedentary person, as he has said in the beginning. So a lot of behavioral therapy, a lot of motivation, dietary counseling, exercise first thing, Second, you go to pharmacological therapies, and because he is diabetic, you have the option of using a GLP-1 analog, which gives a fair amount of weight loss, which is now even recommended in other countries